Next, I invite Dr. Naresh, sir. He'll be talking to us on the neovascular spectrum of the pachychoroid diseases and telling us how to identify and manage these vascular changes. Madam, please come in front, ma'am.
A very good morning to one and all. I will be speaking on neovascular pachychoroid, identifying and managing the vascular changes. So this is just a sort of overview. So you have to remember that the venous drainage system is divided into 4 quadrants, and from each quadrant the venous blood is drained into the respective vortex vein, and there is no intervortex anastomosis most of the times. So basically there are concerns that it could be a heritable anatomical predisposition some patients have for pachychoroid spectrum, because even with a sort of congested hyperpermeable choroid, not all patients develop the disease spectrum. So there could be overload of the hilar veins, and then there is a compensatory mechanism that sets in. So, and the RP is able to overcome the chronic fluid overload, and these patients may not progress further. So we don't know what really triggers some patients to develop symptoms and signs. And once there is not able to compensate, there is a decompensation. You can get dilated hilar vessels, and then the overlying satellars and the choriocapillaries get affected. There is a ischemia that sets in, and you get all sort of complications like you can get CSCR, PNV, PCV. So basically the dilated vessels that you see in PNV could be the dilated hilar vessels. So there's just a vascularization, there is no aneurysms. And when the aneurysm develops, we call it as PCV. So this is the whole gamut how it progresses. We'll go to the PNV. So this is refers to neovascularization in eyes with thick choroid, and there is no aneurysmal lesions at the end of the vasculature. And whenever you see a flat FIPED, that is flat irregular PD, you have to rule out there is no neovascularization, and OCTA is very good for picking such cases. And you have to remember that these cases can develop into PCV also. So this is one of the case. Here you can see this is a flat irregular PD, and you see here this is a hilar vessels. So most of the time where you see the FIPED, you will see the morphology is different. So look at these vessels, because the thickness could not be uniform. Sometimes it could be localized and focal. And there's a co-localization. Wherever you hilar vessels, on top you will see the FIPED. And if you see the FFA, you don't really pick up the neovascularization. But if you do OCTA, you see the vasculature in a very nice way. So this could be that why OCTA is sensitive is because they are in one plane, the vessels are more mature, and there's no drusonide material, so segmentation is better. So that's why you get better images, or why the OCTA is better to pick up neovascularization. And the patients may need less anti-VEGF because there are lower levels of VEGF, and then you have to rule out whether the leakage that you see is purely from the membrane neovascularization or CSR component also is there. So always do an FFA. Sometimes you may see a focal leak. So there could be a combination of both, or one could be more playing a greater part. So try to rule that out. This is one of our cases, 39-year-old male, chronic CSCR, 6/9 vision, and you can see this is a flat irregular PD, DLS. There are hilar vessels here, and the OCTA picks up the neovascularization here. So the patient received 2 anti-VEGFs, and the patient did well. This is another case. The patient did not really do well. Even with 6 injections, it's not getting dry. So I think PDT could be one option in this, but the availability is an issue in India. And then we come to the PCV. So basically, you need to rule out what you're dealing with, because whether it's a neovascular AMD or PCV. So there are some pointers. There's a higher incidence of SRD, greater SRD height, less interretinal edema. So all these things can lead you to the diagnosis of PCV. Basically, it is a type 1 variant. So earlier we used to think that the polypoidal lesions are deep-seated, but actually they are just at the level of the RP and the Brooks. So the layer in between, this all things happen. So this is one case of, you can see on ICG how well you can see the BVN. These are the polypoidal lesions. Here also you can see a big BVN with polypoidal lesions. OCT also is a good way to at least pick up that, or you could suspect that you're dealing with PCV. So you can see there's a large PED, there's a notch here, and this could be PED harboring the polyp. So this is another case. So you can see there's a subretinal lesion here. OCT, you can see a flat irregular PED with SRF, and this is the ICG. And fast octa also is very good to look to the extent of the VVN, and it picks up the polypoid lesions also. And this is the corresponding octa. So you can see the BVN is so nicely seen here. The polyps are not well seen on octa. So various classifications are there, type 1, type 2, type 3. So that will tell us the prognosis also. So this publication also is there. So this is one of our cases. Both eyes, there is a subretinal lesion here, and there was a NSD with PED, and the patient was diagnosed to have PCV. So you can see there's a small leak here, CSR type leak. There's a polyp, bunch of polyps, and this is a flat irregular PED. So both eyes had PCV, and the patient underwent multiple injections in both the eyes, and unfortunately in the left eye there was a rip. So one thing you have to remember is that sometimes serous PEDs also can rip. It's not always that it has to be a fibrovascular PED. Most of the time rip happens if there's a harboring a CNVM, and it usually happens after the first couple of injections. When the membrane retracts, it can cause the RP to rip. But in CSCR, if it's a large serous PED, there's a sudden exudation, that also can cause a rip. So there's a large rip the patient developed. And the other eye also had a large PED with fluid, and then we gave brolucizumab, and the patient is doing well. This is another case. You can see there's a subretinal bleed, and there's a large PED with subretinal hemorrhage. The patient underwent pneumatic displacement with anti-VEGF injection. The other thing is that if you see such a large area, around up to 11 to 20 disc area of subretinal hemorrhage, there is a higher risk of breakthrough vitreous hemorrhage when you inject gas. So this patient developed breakthrough vitreous hemorrhage, and then I had to take for surgery, and then the patient did well. This is another case. You can see the PED and the corresponding ICGs, and this patient also underwent gas displacement, and then the patient did well. So basically, the level 1 evidence supports the use of anti-VEGF monotherapy or combination therapy, but studies have shown that combination therapy could be better. It has a better closure rate of the polypoidal lesions, but the PLANET study shows that aflibercept is as good as PDT. You don't have to really do a combined. If you're using aflibercept, that is quite good. And the Hawk and Harrier also showed that the brolucizumab is as good as aflibercept in the management of PCV. So there's a link between CSCR, PNV, and PCV. So PCV can develop at the margins of long-standing type 1 CNV. And by a study by Adrian Fung, he showed that 36% of their patients with chronic CSCR and type 1 NV went to develop PCV. And this is publication from Dr. George. So 3.7% of the PCV cases had typical CSCR leak in the same eye. And there could be some histological variations why some patients, they don't develop the typical neovascular AMD. The RP or the Brooks could be thick. So the vasculature remains underneath that, becomes more mature. It could hyalinize, and you can get PCV-like features. So to conclude, multimodal imaging is important. Recognition of the pachychoroid state is essential for disease prognostication and management. And there are a lot of management options. I think now looking at the new data available, we could think of vortex vein decompression or some things, because whatever we are doing, anti-VEGFs, they don't really remodel the vasculature. the hyperpermeable and thickened choroid remains there. Anti-VEGFs reduce the exudation, but we are not treating the basic problem. So there is I think time has come that we should look at more sort of surgical managements and see how it goes. And we need longer follow-up studies to assess the long-term visual outcomes and recurrence rate. We need more imaging biomarkers so that we can prognosticate and we can look at the treatment response. Yeah, thanks for a patient hearing.
Thank you so much, sir. My question is that, is there a way to differentiate between a type 1 AMD CNVM versus a Pachy CNVM? Is there a difference in the clinical characteristics which you have and the anti-VEGF molecule of choice and the dosage regimen which you would choose?
Excellent question. I think that we are still learning about it, but the more understanding, what I do personally is that because I see a lot of Caucasian patients, so first thing I look is the choroid. If I see a choroidal vessel, large choroidal vessel decompressing the inner choroid, and then there is a type 1, then I'm really going to push that into either a pachychoroid related CNV or PNV. If I don't see a larger choroidal vessels, and in addition to that, I see a typical signs of AMD, drusen, ooze, or you see hyperreflective dots. So then I would consider that as more a type 1 related to AMD. What I have realized, I would love to hear from others, that with PNV cases, the disease is very localized, but in AMD cases, the primary pathology is much more distributed because you are seeing drusen there, you are seeing SGT, you are seeing some evolution of the drusen at different stages. But when we talk about PNV, it is very much localized due to the larger choroidal vessel underneath. Do you think I'm looking at it right?
I don't know, because we don't see that much of SDD here. We do see SDD, but then now if I see SDD, then I show my fellow this is SDD. Because I think we don't see that much. But we don't see that much drusen in our AMD patients either. I don't think it'll influence my choice of injection as long as they get it.
Yes.
Sorry, I didn't answer the second part. Choice of injection, we have very limited choice, yes, but if I'm seeing something PNV, then I'm thinking about really starting somebody on HD or with faricimab. That is for sure.
Present scenario, if the patient is not responding to anti-VEGFs, patient has PNV, what options we have?
I don't think PNV patients really do that badly. It's more of a very indolent course. So I think if there's a little fluid and vision is maintained, I don't go further. But I would be more aggressive if they have a large pigment epithelial detachment or something, then I would be more aggressive. But PNV is generally a little indolent.
I think we are all underdiagnosing exudative PCV because in the one.
Yes.
So we only look at subretinal hemorrhage, then we suspect PCV.
Yeah.
So I think we should keep that also in mind.
And you can do it fairly well with a B-scan OCT also now. So the picture you showed, those sub-RP hyporeflectivity is very typical.